is a very common finding in IVF-derived embryos, and they affect 15 to 90% of cleavage stage embryos and from 4 to 30% of blastocysts. May refer to embryos composed of a mixture of different of cell with different chromosomal abnormalities. In this case is called mosaic aneuploid embryos, or a mixture of diploid and aneuploid cell line, mosaic diploid aneuploid. In this presentation I will refer to this latter one, and I will call it mosaic embryos. Mosaicism arises from mitotic errors occurring after fertilization, and the number of aneuploid cells within mosaic embryos depend on the time at which the mitotic error occurs. So if the mitotic error occurs in the first division, the number of cells within the embryo will be higher compared to those in which the mitotic error occurs later in the division. The best characterized types of mitotic errors resulting in mosaicism are sister chromatid mass segregation, in particular anaphase lagging, producing cells with the single chromosome loss, or nose disjunction, producing cells with reciprocal gain loss, or endoduplication, in which the cells are composed with single chromosome gain. But mitotic error may also occur from faulty corrections of chromosome breakage leading to cells with segmental abnormalities, or a combination of more mechanisms in which a mosaic embryo is composed by complex abnormalities. Usually, mosaic embryos have not been considered for transfer. This is because it was deemed abnormal. But now we know that mosaic embryos can develop into healthy newborns, and also we know that the mosaic embryos have poorer outcomes than those of the euploid embryos. Today, the available data on pregnancy outcome are still limited. Indeed, no more than 300 mosaic embryos have been reported in a single study, and doubts remain as to which characteristics of mosaicism, such as the type and the level of mosaicism, correlate with clinical outcome. In addition, the potential risks associated with the mosaic embryos transfer are still unknown. As a consequence, some argue that mosaicism should not yet be reported, or reported just for some kind of mosaicism, or that embryos classified as mosaic should not be transferred. To answer to this question, we further investigate whether the extent and the type of chromosomal mosaicism may influence the outcome of mosaic embryos. To this end, we performed a multicentric prospective study involving assessment of more than 2,000 PGT cycles obtained from May 26th to January 2020. Then the clinical outcome of mosaic embryos was evaluated compared to different groups of mosaic embryos and euploid embryos. Here, the participants to the study, there was 7 different participants, IVF clinics and a genomic laboratory. We obtained more than 12,000 blastocysts that were analyzed by NGS. More than about 2,000 were mosaic, and the detailed analysis of this mosaic embryo are reported in the e-poster P51. I will invite you to have a look. We transferred 1,000 mosaic embryos in 923 women, half of which had no euploid embryos after treatment. Among mosaic embryos, we obtained 516 mosaic embryo composed with the whole chromosome, and the remaining composed with the segmental abnormality. The outcome of mosaic embryo were then compared with those obtained after the transfer of about 5,000 euploid mosaic embryos that were used as a control. Here the first result. We compared the mosaic outcome with those obtained after the transfer of euploid, and here the result. As you can see, the implantation rate obtained after the transfer of mosaic embryos was significantly reduced compared to those obtained after the transfer of euploid. Similar results were also obtained for pregnancy rate, reduced pregnancy rate, and we obtained an increased miscarriage rate. Demonstrating that the mosaic embryos show a significant reduction in clinical outcome compared to euploid one. Then we compare the different groups of mosaic embryo. Here, the group were based on the different percentage of mosaicism in the embryo. This graph represents all mosaics. As you can see, we did not observe any significant difference in implantation and ongoing pregnancy rate among the different groups of mosaic. But if we observed only wool chromosome mosaic, this difference was significant and showed a reduction with an increase in percentage of mosaicism. Segmental mosaic did not show any difference. And also when we divided the wool chromosome as a segmental mosaic based on low or high level of mosaicism, we again found a significant difference between low level and high level mosaics in implantation and ongoing pregnancy rate for wool chromosome mosaic, but not for segmental. Then we analyzed the different types of mosaic embryo, segmental loss, chromosome loss gain, complex mosaic. And as you can see, we found that there was no significant difference between mosaic with monosomy and trisomy. Again, euploid showed the highest level of pregnancy rate, and this percentage decreased, moving from mosaic with segmental to mosaic with one chromosome, two chromosome, and finally complex mosaic showed the lowest level of pregnancy rate, 20.8%. Finally, we combined the type and percentage of mosaicism. We used euploid as a reference, and we found again that also with these subgroups showed a significant reduced ongoing pregnancy rate compared to euploid. In particular, segmental with low and high level mosaicism, this did not show any difference. Any difference also for one chromosome, two chromosome with low level. Any difference between one chromosome, two chromosomes with high level of mosaicism. Some difference in the complex groups with the low and high level. So from this result, we can draw a sort of classification of mosaic embryos based on their characteristics, in which segmental show the best, the higher level of pregnancy rate, then the mosaic with one or two chromosome and complex, and the last were mosaics with the higher level of mosaicism. So in conclusion, we can say that the present study is the largest data set of transferred mosaic embryos outcome reported today. 1,000 mosaic embryos were transferred. This study shows that the mosaic embryos should be considered for transfer because hold the potential to implant, resulting in the birth of a healthy baby, and also show that the priority for transfer should be given to euploid embryos, and that the mosaic embryos have different clinical outcome according to their characteristics. In particular, the transfer of embryos with the segmental, either low or with high level of mosaicism, is associated with an improved clinical outcome compared to other mosaic groups. And also we show that the high-level complex mosaic subgroup have the worst outcome. The newborns from our sample have been healthy by routine neonatal examination, but of course we need a comprehensive analysis of obstetrical and neonatal outcome of transferred mosaic embryos. And in addition, transfer of mosaic embryos with the viable aneuploidy should be considered with extreme caution. This is because we don't have right now sufficient data to draw any definitive conclusion about the outcome of such embryos. And also, results on segmental mosaics need to be confirmed by higher number. This especially when we want to compare groups with different percentage of normal cell or with different type of abnormality. Finally, I would thanks to all the centers that participated to this study, and thank you for your attention.